Well, good evening from Birmingham. Welcome to the fifth installment of our Masterclass series from ASMI in Birmingham, Alabama. My name is Mark Rothermick. I'm one of the sports surgeons at Andrews, and I'll be moderating our session this evening. We'll start by going through the objectives for the evening. So this Masterclass series is designed to provide a more in-depth study of very common sports medicine problems. And the hope is that at the conclusion of this webinar, we hope that each of you will be able to identify some of the advances in treatment of injuries, specifically tonight to the rotator cuff. We're going to go through the current surgical techniques for rotator cuff repair, and we hope to demonstrate knowledge of rehabilitation techniques for common rotator cuff injury patterns. Our disclosures are listed here, and each of us will go through our disclosures individually as we go through our individual presentations. And so I'll go ahead and get started. So our first subject this evening, we're talking about rotator cuff disease all night. I'm going to be the first presenter to go through specifically classification systems and the diagnosis of rotator cuff disease. Again, my name is Mark Rothermick. I'm one of the surgeons here at Andrews Sports Medicine in Birmingham. And so after I speak on classification and diagnosis, Dr. Lyle Kane will talk about current surgical techniques for rotator cuff repair. And then after Dr. Kane's finished, Dr. Kevin Wilk will discuss rehabilitation of rotator cuff injuries and surgery on the whole spectrum, from small partial thickness tears to some of the massive retracted tears that we see. And then we'll have questions and answers after that in a panel discussion format. So if you have any questions that pop up throughout the presentations tonight, we'll keep an eye on them. Please submit them on the Q&A format. At the bottom, you can see the Q&A function, and we'll have a running list of questions that I'll keep an eye on throughout the presentations this evening, and then we'll answer them all if we can at the end. And so again, we'll start tonight. I'm kind of the warm-up act here, so I'm going to talk about classification and diagnosis for common rotator cuff disease patterns. A lot of this will be review material. We'll go through some of the anatomy and common classification systems to get started. And again, here are my disclosures, none of which pertain to the subject matter this evening. So the goals for this initial presentation, again, are to describe the anatomy of the rotator cuff complex and some of the common rotator cuff tear patterns, to discuss the relevant pathophysiology of common rotator cuff injuries, and then to discuss some of the more commonly used classification systems for rotator cuff injuries. And you'll see as we go through, there are several ways to describe rotator cuff injuries. That matters in terms of specifically research that we do and how to describe things using a common language. And so a few of these slides early on will be familiar pictures of some of the anatomical descriptions of the different components of the rotator cuff. So just to start at the very beginning, the description of the rotator cuff anatomy begins with each of the individual muscles and tendons that attach from the scapula to the humerus. So the subscapularis anteriorly, the supraspinatus superiorly, and then posteriorly the infraspinatus and the teres minor. And we'll talk about each of those in turn in terms of the pathophysiology as well. There's a few different ways to describe the anatomy. I like looking at these different muscles and tendons independently, but in reality in the clinic, especially when we talk about superior and posterior tears, so the supraspinatus, the infraspinatus, and the teres minor often is treated as one sleeve or one complex, with the subscapularis apart as the anterior function, different in terms of the pathophysiology. Some of these are the old Netter classic pictures that look at the origins and insertions. Many of us will remember that we were grilled in training that there were 17 different muscles that originated off the scapula. Thankfully tonight we will only be discussing 4 that comprise the rotator cuff, but this is relevant in terms of surgical anatomy. When there are injuries that require surgical fixation, it's important to remember the locations of each of the insertions, and we'll go through each in turn. This is a classic paper by our very own Dr. Dugas from 2002. So we're coming up on the 20-year anniversary. We'll have to be sure he knows that. The 20-year anniversary of this classic paper that he did back in residency. So you'll see some names on there: Russell Warren, Pete Millett. This is an old HSS study from New York that looked at the anatomical description in great detail of the dimensions of the rotator cuff insertions. This paper for the past 20 years has been really what we use to describe the footprint of the rotator cuff on the humerus, and specifically the dimensions of the supraspinatus, infraspinatus, and teres minor on the greater tuberosity, and then the subscapularis on the lesser. Important study that really defined mathematically the dimensions of the rotator cuff. Now, as we discuss rotator cuff pathophysiology, this is where we really see the clinical correlation. When we see these patients in clinic, oftentimes patients with full thickness retracted tears have the inability to do many of these motions, and specifically flexion and abduction. We talk a lot about the origination of the abduction moment of the arm, bringing the arm out and up over the head, and then terminal flexion oftentimes is what we commonly see injured in the most common injury pattern, which is a tear of the supraspinatus. We see limitations in flexion. I always ask patients if they can get to the top shelf, and usually they say, I don't want to, and sometimes they say, I can't, if it's a full thickness retracted tear. So it's important to talk about what specific motions are limited in patients. Dr. Andrews has an old saying that the diagnosis is made 90% of the time by the history alone before you even touch the patient or look at any advanced imaging. Just the patient telling you their story of what happened, how they injured their shoulder, describing what their limitations are, usually can get you there in terms of the diagnosis. And so that's the most important components of the pathophysiology, is the patient describing what their limitations are, and that's helpful in terms of making the proper diagnosis. And so as we talk about rotator cuff pathophysiology, this is what it looks like. This is a full thickness tear of the supraspinatus, and we'll talk a little bit about the differences between small full thickness tears, massive retracted tears, and partial thickness tears as well. But I think this is a good picture to look at anatomically. This is what a rotator cuff tear looks like that we typically see, especially for patients with superior pain and an inability to abduct and forward flex. It's a full thickness supraspinatus tear. Some of these are old photos that really show some of the physics and the kinetic dynamics of the motion of the shoulder. We can see different patterns of glenoid wear, and also a balancing of the net forces. So for those who like physics or engineering, these photos might be nostalgic to look at the different forces, the vectors of motion that can help tell us what the issue is in terms of the pathology. These are balanced forces. In a perfect ideal world, when there's pathology, they become imbalanced. And so we typically see on radiographs or on advanced imaging proximal humeral migration when there's a supraspinatus tear. Some of that is from the imbalance of the forces, that the deltoid force and the imbalance of the rotator cuff tendons can lead to an imbalance of those muscular forces. That can lead to instability of the shoulder, and it can also lead to radiographic changes, as we've said. So this is important. These are important things that we can see clinically. That is really the foundation for understanding rotator cuff pathophysiology. Now, in terms of epidemiology, some of the common statistics that are quoted, this is an increasingly common problem, obviously, in elderly patients. This was historically known as an old person's injury, rotator cuff disease. As the population has become more active with recreational weekend warriors, we've got our active middle-aged patients. We are seeing a steady increase in rotator cuff incidence and prevalence each year. And so some of the statistics that are commonly quoted, these may show up on tests and training. This always surprises patients when we say about a third of the population over the age of 60 actually has a full thickness rotator cuff tear. Many of these are asymptomatic. Many of these are chronic degenerative injuries that have gradually worsened with wear and tear over time. 65% over the age of 70. So a majority of patients, it flips over in your 60s, that now a majority of patients are walking around with a full thickness rotator cuff tear. And so this is a very common problem that we see in clinic. And again, for most patients, it's asymptomatic. And a lot of patients come in and say, I didn't do anything. I didn't fall off a ladder. I didn't have an acute injury. This has probably been there for a while, or it's been cooking for a while, where it's a chronic degenerative change. We have seen over the past 2 years, there will be a lot of studies that come out in the future about how disease epidemiology has changed from COVID. What we've seen in this clinic anecdotally, certainly in my practice, has been a real spike in rotator cuff injuries over the past 2 years. And we've talked about this amongst ourselves. One thing we've seen, we talk about how for those active middle-aged patients, it's a weekend warrior injury from softball leagues or from working in the yard. With COVID, people were working in the yard every day. It wasn't just a Saturday injury pattern. It was every day. People are working from home more often. People are doing their own home projects, a lot of DIY projects around the house. We've had painting injuries. We've had construction injuries, obviously cleaning the leaves out of the gutters in the fall. There's been a variety of injuries that have happened over the past 2 years that typically were isolated to the weekends and have been much less common before COVID. So this is one that I think we'll see in the future. One of many things that we've seen a spike from the COVID pandemic. Certainly much more rotator cuff disease due to patients working from home and doing some of their own projects at home. And so in terms of classifying rotator cuff pathology, I think it's important to really identify a couple different things, both the quality of the tear, the location of the tear, the size and shape of the tear, and we'll go through all those different mechanisms. It's important to tell the difference. So clearly this last one, a small full thickness supraspinatus tear, is very different than the chronic retracted massive rotator cuff tears. You can see how different those two pictures look. And so it's important to describe that both when we talk clinically and when we interpret imaging to discuss the surgical management might be different between these patients. And so here's another look. This is a partial thickness articular sided rotator cuff tear on the left. We've got a massive retracted full thickness rotator cuff tear on the right. And so the treatment and the algorithm of options are going to be different for these patients. And so important to be able to identify what these look like. This is what it looks like clinically, where on the left, we see a rotator cuff tendon that looks pretty good. They may have a small bursal-sided injury, but on the articular surface, at least, looking at the humeral head and in the undersurface of the rotator cuff tendon, it's obviously intact compared to the photo on the right, where there's a large retracted tear. It's important to be able to tell the differences clinically when interpreting imaging and knowing best how to describe these. So in terms of classifying rotator cuff injuries, there's a few different ways to do it, and it's important to be fluent in all of these different classification systems. We talk about the etiology of tears, whether it's a compressive or a tensile type tear. We'll talk a little bit about tear quality, both partial thickness and the complete retracted tears. We'll talk about the Gutalier classification. It's a classically tested and clinically relevant classification in terms of deciding the best treatment course for a patient. And then obviously tear size to be able to determine and be consistent with tears that are small, medium, large, or massive. And we'll talk about the differences in that. So in terms of rotator cuff classification, we talk about, in terms of the etiology, compressive tears are very common. So we describe compressive tears as occurring from external compression from the coracoacromial arch and the acromion. And so in terms of the anatomical description, this is a classic impingement syndrome. It leads to bursal surface tears. So the bursal surface is the top of the rotator cuff tendon, that space that's in between the rotator cuff, the acromion, the coracoid. When there's a compression injury, this leads to bursal-sided tears. We talk a lot about the Bigliani classification for the acromion. So this is viewed on the scapular Y view. You can see on the left that acromion looks pretty flat. In the middle, a type 2 acromion has a little hook at the end or a little curve, and type 3 has a very prominent hook. And so when we talk with patients about this, it's important to recognize that a type 2 or a type 3 acromion, which by the way make up about 90%. When we see patients in clinic, very few have a type 1 acromion. The textbook says every acromion should be flat. In reality, it's about 10% that is type 1. Almost everybody has a curve or a hook. And so what that means over time is that's going to lead to compression and certainly impingement and bursal surface pathology of the rotator cuff. The opposite of a compressive type tear is tensile tears. Those typically occur from overload in the tensile mechanism. These can be acute injuries or chronic degeneration, but these lead to the opposite, articular-sided or undersurface rotator cuff tears. And so we can see these clinically. That first MRI that we showed on the left showed a partial thickness underside or articular-sided rotator cuff tear, which is typically caused by a tensile type injury. So important to be able to put together from the etiology of the tear what some of the different mechanisms can be in different types of compressive versus tensile type tears. This is really the classic Goutallier classification. When we look on the outlet view on the MRI, you can see the difference as we go from a grade 0 to a grade 4. And what this classification represents is when we look at the supraspinatus, we're looking at the quality of the muscle versus the infiltration of fat. And so this is important in chronic degenerative tears. We can see in grade 1 or type 1 some fatty streaks in there. As we get into type 2, we can still see some muscle that's over top the Y of the scapula, and so it's more muscle than fat. Type 3 is kind of classically equal amounts of fat and muscle. And then as we get into the grade 4, type 4 Goutallier classification, it's almost entirely fat. When we see this is really concerning for the quality of the tissue in terms of a rotator cuff repair. If we see a patient that has a chronic retracted tear, and when we look at this view and see it's either equal grade 3 or certainly for more fat than muscle grade 4, we get really concerned about the ability to repair that rotator cuff. And that's when we start thinking about alternative options, potentially a reverse total shoulder arthroplasty, as opposed to having poor tissue that could potentially fail and lead to a revision setting. It's important to be able to describe the shape of a rotator cuff tear. These are some of the classic descriptions of, on the left, a crescent type tear versus a U-shaped tear. When we see these large U-shaped tears, they could potentially require some side-to-side suturing, so it changes our technique a bit. The third photo there is a classic L-shaped tear. And then on the right, we see the massive retracted tears that again could require some of the different techniques that we talk about. You've heard about patch augmentations. It comes into play for these massive retracted tears, and we'll let Dr. Kane talk about that in a bit. In terms of the size, the importance here is really the consistency, to be able to consistently describe tears by size. And the goal for this really in terms of the research setting is to be consistent. This is a study that is not in press yet. We're currently working on a study that looks at a large registry of rotator cuff tears that have been operated on here in our practice. And this is a good example of why it matters to be consistent. So we talk about outcomes by a rotator cuff tear size, and we're very specific about which rotator cuff tears are small, medium, large, and massive, because we think that that helps in terms of the accuracy of our research, to be able to accurately describe. This is half of our patients, 51%, had small tears versus medium, large, and massive. So really when it comes to describing things in research papers and also clinically, when we talk about correlating what we see clinically with what we see in the operating room, it's important to be consistent with the sizing. So we're going to kick it over to Dr. Kane next. Thank you for your attention for the first part. Again, the warm-up act tonight, talking about classification and diagnosis of rotator cuff injuries. Next up, Dr. Kane's going to talk about what we are doing currently in terms of surgical techniques for rotator cuff repair. And then following that, Dr. Wilk will talk about rehabilitation of rotator cuff injuries and surgery from partial to some of the massive retracted tears that we see. So for anybody that has questions, please again submit those on the Q&A function, and I'll be moderating those for the next few presentations, and we'll have a Q&A session at the end to discuss some of these questions. And so next up, we'll leave it to Dr. Kane to talk about surgical techniques for rotator cuff repair.
All right, thank you, Mark. You guys can see my screen, hopefully. So I'm going to talk about our current surgical technique and kind of the rationale of how we got to this point and why we're using this technique, and go through a little history of what we've done in the past. So I've been here for 23 years now and seen a lot of advancements in rotator cuff repair techniques. The anchor morphology, the sutures are better, the rehab is probably better, Kevin will tell you, but I think ultimately we still have problems with rotator cuffs because of tissue quality, and we'll kind of go through that issue. So I'm going to talk about our rationale behind our current technique, and I'm going to show you some of the pearls that we have found over the years for arthroscopic rotator cuff repair. So what is the function of the rotator cuff? I know Mark just went through some of the biomechanics and the tear classification. Well, in Alabama, it's really for one purpose, and really the only purpose is just for holding up trophies. So we have to hold up, at least every other year, we hold up a crystal football or one of these large, kind of awkward looking pedestals with the football on the top. Even our players have to hold it. You know, Tua and these guys have to hold the pedestal up. And even Coach Saban. I mean, you know, Coach Saban's about to turn 70, and or is 70, and has to hold the trophy up. So you see, he got a little help from our offensive lineman, but you know, rotator cuff's important in Alabama for lifting up trophies in the season. So how do we get to this point? Well, I'm going to talk about the biomechanical evaluations we've done over the past several years, looking at different rotator cuff repair methods and kind of what we do because of that. So historically, the mini open double row was the gold standard. It was kind of the thing that Dr. Andrews did for 20 years or so. And we did it through a small incision in the deltoid. It was about a 4 or 5 centimeter incision. We'd split the deltoid, and we did this open essentially. So we basically put anchors on the medial part of the humerus. So the anchors would be here. Then we did bone tunnels laterally. We had modified Mason Allen, which is a locking suture that we tied down the bone tunnels. We felt like this was a really nice double row attachment that gave a wide surface area, which matches that 13 millimeter width that Mark discussed, that Jeff Dugas found in residency at HSS. It also increased the contact area and contact pressure, and had great fixation strength. So that was our technique of choice in the 70s, 80s, and really up until the late 90s. Dr. Andrews did this because he thought it really restored the native anatomy. This was long before Jeff's article on the actual anatomy of the cuff. And it had the strongest repair. He felt like this was the strongest in his hands, and it gave you kind of a belt and suspenders. So if the medial row failed, you always had the lateral row. If the lateral row failed, you always had the medial row. So to tear the rotator cuff, you either had to tear through the tissue, or you had to fail both anchors and the bone tunnels. So in 1999 and 2000, what Dr. Andrews has termed the new decade of the new millennium, many times we're past that now. But back in 2000, we started moving towards arthroscopic rotator cuff surgery for a lot of reasons. We had friends in all the societies that were doing it and talking about it, and you know, we wanted to be on the cutting edge. And so we tried to duplicate our mini open repair, and we started doing a double row rotator cuff repair arthroscopically in 2000, which was pretty advanced at the time, but we didn't have great implants. What we would do is we would take a lateral threaded anchor, and we would do a simple stitch to repair the rotator cuff laterally. And then we kind of blindly use this Mytech, what's called a cuff tack. It was a PLLA tack that was purple, and you'd put a guide wire in, rim a little hole, and then tack this thing down. It would compress the medial row. And it worked pretty well, but the tacks didn't hold great, and they weren't a great implant, and they kind of went off the market. But that was our first initial attempt at a double row arthroscopic repair. But we were pretty nervous about the security of our repairs. You know, we had athletes having this, we have friends having this, we have, you know, all of our patients are, you know, we don't want to lose, we don't want to have one tear, so we're concerned, and so we decided to go to the lab and really check out if we could mimic our mini open double row with an arthroscopic technique. So we know that failure of rotator cuff can happen for a lot of different reasons. I think back in those days, technique failure was a huge reason, either inadequate fixation, The implants were not great. We were just learning how to do it. And there's a pretty steep learning curve to doing a good arthroscopic rotator cuff repair. Anatomic failure, I think, is a real issue and has been in the past, because traditionally the fixation method for most rotator cuffs arthroscopically was a single anchor. And one single anchor obviously doesn't restore the footprint. And then, of course, we had mechanical failure. If we look at the technology we have now in terms of anchor fixation and suture fixation, the materials themselves are so much stronger than they were 20 years ago that oftentimes anchors would pull out or sutures would break. And then lastly, and probably most importantly today, failure of biology. The rotator cuff eventually has to heal back to the greater tuberosity. If it doesn't, you're going to end up with a failed repair. It's eventually going to tear loose, or the actual rotator cuff tendon will tear. So the question we had back in 2000 was, how strong is our current repair technique, the mini open, double row? And then can we duplicate this with a 2-layer arthroscopic or a single layer arthroscopic technique? So we went to the lab and did 3 studies, all published in the major journals. So the first study was a mini open double row, which was our basic standard mini open surgery we've done for 20 years, versus our arthroscopic single anchor. But we modified this by putting a locking suture in called a modified Mason Allen stitch. And we did this in the lab. It was a little bit cumbersome to do, but we did it and we got really good fixation. We thought this was going to be a great opportunity to kind of match what we did open. And what we found was that the mini open was much better with initial tensile strength than the single row arthroscopic knots, and that the arthroscopic knots had significant gapping with much less force. And so if you watch these instron pulls, the tendon pulled away from the bone with about 200 newtons less force with the arthroscopic technique than it did mini open. So not nearly as good. So that was a failure. We published that in AJSM, I believe, in 2003. The second study was mini open double layer again against either a single layer of anchors, which was the standard arthroscopic technique of the day, or a single layer of bone tunnels, which many people did open back in the early 2000s, late 1999. And these were both standard techniques that we could do. We had a way to do bone tunnels arthroscopically, a device called a Curve Tech, and we had a way to put anchors in, obviously arthroscopically, but we weren't sure how it related to mini open. This paper was published in AJSM back in 2003. We had 12 matched cadavers, and what we found was essentially that the transosseous tunnels themselves, which was a very common way to fix rotator cuffs, was by far the worst fixation. After only 500 cycles, the sutures basically cut through the tuberosity like a giggly saw, and it failed. The anchors were a little bit better. They lasted 1,400 cycles before they failed, and what we called the anatomic repair, or the double row repair, was much better. It lasted almost 3,700 cycles before it had any gapping. So again, arthroscopic techniques were not as good at that point compared to the mini open. The last study we did was published in JBJS. It was the mini open double row versus an arthroscopic double row. And this technology came out about 2002, 2003. We didn't really have a way to do an arthroscopic double row before this, but we had a medial corkscrew anchor. These were Mytech anchors, a medial corkscrew and either a lateral corkscrew, or there was a device that was called, I think it was the Bio Nautilus Mytech, that was essentially a suture you passed through the rotator cuff and you hooked the loop and pounded that in the bone. And it was a knotless version of a lateral row. So we did one of each, matched pair cadavers in 30 different cadavers. And what we found was that in those 30 cadavers, the cyclic loading and load to failure were very similar. And we found that we could, through an arthroscopic double row, make a similar type structural repair to a mini open double row. So this was the first evidence we had that we might be able to make this work arthroscopically. So as a result, we started doing the arthroscopic double row suture bridge in early 2000s. Subsequent authors, Peter Millett and others, showed that the double row suture bridge transosseous equivalent is very close to and just as strong as the traditional mini open double row. So in 2003, we started transitioning to all arthroscopic rotator cuff repairs. Now, over the last 19 years, the technology has evolved tremendously. And so our technique has changed. In fact, we probably changed technique. I guess we change technique every few years, maybe every 4 or 5 years, either with a new anchor, a new passing device, some new technique, knotless devices, things like that. And so It's not a static field at all. It's a very rapidly evolving field. So I'm going to show you our current technique, just a little video. We do everything in lateral position. This is a right shoulder facing to the left of the screen. We mark out all the bony landmarks. We always mark the acromion, the CA ligament, the coracoid, and we mark our anticipated portals. The important thing with the shoulder is that you can put portals in a lot of different places. So you don't ever have to get married to one specific spot. You can pretty much put a portal anywhere from the posterior axilla to the anterior axilla if you're careful with your direction. So we first inject the glenohumeral joint with saline. When you do this, if the rotator cuff is not torn, the arm will internally rotate as the capsule distends, which is a pretty good signal that the rotator cuff's intact. If you have leakage through the rotator cuff, it typically doesn't distend. So if you don't see leakage, if you don't see distension and internal rotation, it means that either the rotator cuff is torn or you missed the glenohumeral joint, one of the two, which can both happen. We then put the scope in posteriorly. We do an outside in technique. We use a spinal needle to localize our anterior portal, make an anterior portal. And then once we're in the subacromial space, we also use a needle to localize our lateral portal, which would be for our acromioplasty. This is a right shoulder also. The scope is in the posterior portal. We're going to make our anterior portal using the spinal needle again for localization. We like this to come in about halfway between the subscap and the biceps. It gives you a good angle to do all your work inside the shoulder. Also, a good angle for doing suture management for labor repairs. This guy's got a really chewed up biceps. You can see it's got longitudinal split. So I'm going to do a bicep tenodesis with this case. In 2022, I probably do a bicep tenodesis on 95% of my rotator cuff tears. About the only time I don't do a bicep tenodesis is in a young, healthy patient with a pasta lesion or something where there's not a lot of damage. But in most patients, especially older patients, older than 50, I do a bicep tenodesis with the rotator cuff repair in most cases. I do it subpectoral, as I'll show you in a minute. So we're going to clean out the subacromial space. We still do a acromioplasty and a subacromial bursectomy. I know some people that's controversial. Our feeling is that the rotator cuff is going to have some swelling and thickening during the healing. And we want to make sure it has a smooth surface to rub against and it also has plenty of space. Oftentimes I'll look back inside the glenohumeral joint. This is something that I know a lot of people don't do, but in some rotator cuff tears, it's really hard to see anchor placement on the articular margin. So I like to put the scope back in the glenohumeral joint and then look inside the glenohumeral joint while I'm putting my anchors in. So this anchor is coming in through an accessory portal just off the acromion, which I localize using a spinal needle to make sure it's in the right AP plane. And then I'm going to put the anchors in. These are all suture soft anchors, 2.6 millimeters we've been using for several years now. Really nice small anchor that you can put multiple along the articular surface. And you may notice I hook the drill guide right on the articular surface because I want the anchor to be basically hugging the articular cartilage. If you look at the anatomy of the supraspinatus tendon, it attaches directly to the articular margin. As you move more posterior, there is a little bit of a gap in the bare spot of the humerus, but for supraspinatus, you want it to be right on the edge. And so these anchors are very strong. They rely on cortical fixation rather than cancellous fixation like a screw-in anchor. It's also important to rotate the arm to allow your drill guide to be perpendicular to the humerus. If you're putting this anchor in that I'm putting in now, that's an anterior anchor, and you don't rotate the humerus in external rotation, you may skive off the front. And I've seen people skive into the joint. So you have to be very careful about your orientation. Being inside the joint, looking up at the rotator cuff makes this much easier. I also have gotten used to, for tears that are not really displaced, I'll use some type of bird beak or grasper to go through the rotator cuff and grab some of the sutures individually to make sure I get delamination taken care of. So in a really delaminated rotator cuff, this is not really one, but in a delaminated rotator cuff, I like to use the bird beak intra-articularly to make sure I get that lower inferior delamination with my first couple of stitches and make sure that I don't just get a partial bite from the subacromial space. So then I'll go, once I pass my first couple of stitches through using the bird beak, I'll go subacromial and I'll use a needle passing device. We use the Scorpion primarily for this, and we'll do the rest of the passage from the subacromial space. But this is a really nice technique to make sure that you get the delamination. Just from a suture management standpoint, if you'll watch the anchor as you're pulling sutures through and not your hand or the shoulder, you won't unload an anchor. I've been training fellows now for 22 years, I guess. And anytime I will see them on the screen looking down at their hand or looking down at the shoulder while they're putting a suture through the rotator cuff, I can just about guarantee you they're eventually going to unload an anchor and pull the suture out of the anchor. So here we're using a scorpion passage device. My goal is to alternate sutures and to have a nice spread all the way from the front of the rotator cuff tear to the back of the rotator cuff tear. If you don't have good spread and you don't put them in the right orientation, you tend to get dog ears. So I like to alternate black and blue. That inherently gives you kind of a ripstop mechanism with each pair of sutures. So the blue sutures, once you tie them, will be a ripstop for the black sutures. And so I do an alternating suture strand. And so you'll see I intersperse the sutures. I try to kind of think of the rotator cuff tear from the beginning and put it into quadrants. This case, I have 2 anchors, so I have 8 sutures. So I try to think of 4 sutures in the anterior quadrant, 4 sutures in the posterior quadrant, and then I try to kind of subdivide those quadrants and make sure I make these sutures evenly pass through the rotator cuff so that I have a nice equal footprint compression and also prevent dog ears. Then I'll start tying through the lateral portal. When I tie my sutures, I like to use the most medial suture or the most central suture as my initial post. And the reason I do that is I think it gives you the best reduction of the rotator cuff tendon back to the humerus. If you start on the front or the back, sometimes you'll tether the rotator cuff anteriorly or posteriorly, and it's hard to get the central portion of the cuff to advance back to the tuberosity. We use a simple sliding knot. It's just 2 throws in alternating fashion, and we slide the knot down. Then with a knot pusher, we'll do a pass point and flip the second knot to make it a square knot by pulling the non-post strand. So I'm holding the post strand in my left hand, pushing with the knot pusher, getting good tension on the knot. It's slid down as tight as it can go. And then I'll keep tension there, grab the non-post strand. And as I grab the non-post strand, I'm going to pull it and pass point, and that will flip the knot and make it a square knot so it won't back up anymore. Great technique for tension type repairs where maybe you're trying to reduce something back to a bone and it's under tension. It won't slide away and you won't get an ear knot. So you can see how that first pair of repair stitches really reduced the rotator cuff. It pulled it over the tuberosity, and now it doesn't really matter. I can go anterior or posterior. I try to make sure that I keep my knot spread. So the knot is going to go to wherever your post strand is. And then I'm going to take 1 strand from each of the 4 knots. I'm going to pull it out my lateral passport cannula and load it into my lateral anchor, which in this case is a swivel lock. I like to use 2 medial and 2 lateral anchors on most rotator cuff tears. Sometimes on a big rotator cuff tear, I may use 3 medial and 2 or 3 lateral. So we use the vapor wand to expose the spot pretty much as far lateral to the humerus as I can. I want to be a good kind of cortical bone rather than humeral head cancellous bone. I'm going to look at the position of this anchor, how it pulls the tissue down, make sure I have tension on all 4 sutures and make sure they're tensioned equally. And then I'm going to put the anchor in. I like to leave these swivel lock or screw-in anchors of any kind. I like to leave the last thread in the cortical bone because I think if you countersink these, you're counting on cancellous bone fixation for your suture to not slide. So I like to keep the last thread in the cortical bone. So I'll do the same thing with the second anchor. That was the anterior anchor. I'll go posterior. The anterior anchor is usually right at the bicipital groove, right next to it. The posterior anchor is going to be usually about 2 centimeters posterior. And I put all these in by hand, cut the sutures, leave the last thread visible so that it's in cortical bone. This is our final repair. We'll usually look at it from the side. Sometimes if I have a little dog ear like this front edge, I'll take the vapor wand and just kind of take the top off that thing just so it doesn't rub on the acromion. My goal is to not have any dog ears. But in most cases, if you have a crescent tear, you're going to have some kind of little uneven window at some point. So this is my final repair. Really good medial compression, good footprint compression, a wide area. Then I walk around the shoulder. I would take the arm and we move it into about 10 degrees of extension just by moving the arm holder. We don't put the patient supine or change position. We just move the arm. I move around to the other side. I'm on the anterior side or the front side of the shoulder now. I make an incision right at the junction of the deltoid, the pectoralis and the biceps. And you can easily get subpec doing this. we'll pull out the bicep. We measure 4 centimeters from the muscle tendon junction, which matches up with the typical place that we put these bicep tenodesis screws in the subpec location. This tenodesis screw is applied. There's a consistent band of fascia at the top of the bicipital subpectoral area, just at the lower part of the bicipital groove, actually, that one of my fellows named the pallium pectoralis. It's a nice little band that you can feel with your finger. It represents the top of the pec muscle, essentially. And if you use 4 centimeters of tendon, you dunk it at the pallium pectoralis, it dunks down 20 millimeters with the swivel lock, you tend to reconfigure the length tension relationship of the biceps. So that's how we keep from developing a Popeye or overtension of the biceps. Once I put my swivel lock in, we like to tie the 2 sutures, one through the swivel lock, one through the tendon together. So that makes this one complex all of one unit. In order to fail this bicep tendon, you've either got to tear through the tendon or you have to pull out the suture and the anchor to get the tendon and the anchor together. So that's our final bicep tenodesis, all done at the same time. The tenodesis adds maybe 5 minutes to each procedure. Very simple to do subpec in the lateral position, which most people have never tried. But we have a different technique. I use, Mark mentioned large tears. This is not a huge tear, but this is a technique I developed. I call it the shoelace technique because it kind of reminds me of tying your shoelaces. We use a single suture, high strength suture polyethylene. We do it just like you do your shoelaces. So this would be at the very toe of the shoe. We do a mattress with the suture pulled underneath the toe of the tongue of the shoe. So now we have both limbs coming out the top. So we just have a mattress suture. Then I'm just going to gradually take each limb and pass it across from inferior to superior, just like you would do your shoelaces. And as you do this multiple times, what you'll find is that it kind of tucks the edges down and gives you a really nice, strong margin convergence closure. My problem with margin convergence historically was if you do several, let's say we did 4 different margin convergence stitches, we would end up with a big ridge, almost like a fish fin of a rotator cuff that would rub on the acromion. So this shoelace technique is a way to make the edges tuck under. It gives you good fixation where you can pass your suture from your anchors medial to this and have a really great ripstop. It gives you good tissue integrity. And I found over the years that I can take even a massive retracted tear and I can really, really pull this thing together. Even if I've got very little tissue left, if you just keep working it, you can pull this thing together and cover the humeral head. And then that allows you to get some fixation. But my reps and my fellows have coined this as a SCR autograft, because essentially what I'm doing is I'm doing, what people do is superior capsule reconstruction using an allograft. I'm taking their native tissue and advancing it almost like a tendon transfer for these massive tears, and they tend to do really well. So the shoelace technique is a really nice technique for a massive retracted tear where you need to pull the tissue together and have good kind of tissue integrity where you can't pull the tissue completely lateral to the humerus. So tenodesis or tenotomy, a big controversy. I think a lot of people are doing more and more bicep tendon work. As I said, I do it on most of my rotator cuffs now, and I do almost always a subpec tenodesis. If I have a small person or an elderly lady that has thin bone and osteoporosis, I may do a tenotomy, or I may use a small suture anchor like a 1/8 anchor to do a tenodesis. But in most cases, I do a subpec tenodesis with a 5/5 anchor. So in conclusion, our goal is to reproduce the native rotator cuff attachment morphology and tensile strength. Our less invasive arthroscopic techniques continue to evolve. I think 5 years from now, we'll be doing something totally different than we're doing now. The newest thing on the horizon for me is all knotless anchors. We've done some rotator cuff repairs where we have knotless medial, knotless lateral with tensionable devices, not just like a suture bridge, but tensionable devices where you can tension it down and continue to tension until you're happy, which is really nice. Currently, we do arthroscopic double row suture bridge on almost every case. Occasionally, if it's a small tear, we'll do a single medial and single lateral anchor. But I very rarely do a single either medial or lateral alone. I usually combine it to do footprint compression. Necessity is the mother of invention. This is one of my patients a few months ago that came in and he had modified his abduction pillow. He had taken a knife and cut him out a little cup holder, which is nice. Nice thought. I've thought about trying to patent this, but I'm not sure that I have to talk to Don Joy and the guys and get it worked out. But pretty good idea. Obviously, he was needing something to hold his Coca-Cola with. Thank you very much.
Great, thank you, Dr. Kane. That's as good as it gets here. And Dr. Kane described the technique for the rotator cuff. I was a fellow here with him 6-7 years ago, and he taught me how to do rotator cuff repairs pretty much word for word that exact same way. And I've done 1,000 of them of my own now, and it's still refreshing to hear Dr. Kane describe the technique and go through some of the pearls. So now we're going to kick it over to Dr. Kevin Wilk, world-renowned physical therapist in our backyard here in Birmingham, to talk about rehabilitation of rotator cuff lesions, non-operative and post-operative programs.
Thanks, Dr. Rademick. It's certainly a pleasure to be here and be part of this particular program. It's really great, I think, to follow up Dr. Rademick and Dr. Kane as far as their presentations and talk about some rehab concepts. I want to thank Mike Oliver, who's running the program tonight, but also Glenn Dortch, who came back from the Masters as a caddy. He's our Director of Education here at ASMI. So here's Glenn in his Masters wardrobe there. My goals are to talk about rehabilitation approaches and guidelines for impingement, compressive cuff disease, as Dr. Rademick talked about, internal impingement like we see in athletes, a little bit on non-op cuff tears, and if we have time, certainly post-op, after what Dr. Kane talked about the differences in the sizes and so forth. Just a little bit of a plug for this Saturday. We run a Grand Rounds webinar. It's free of charge, and Dr. Kibler is going to be talking about scapula evaluation and treatment. It's going to be a deep dive. He's going to kind of give us his inner secrets, so to speak. And to sign up, it's easy. Just go to my Instagram, Wilk_Kevin. There's a scan code. You can sign up. It'll be about an hour and 15 minutes. Obviously, spring break is over. I had the pleasure of going down to the beach for a few days and watched some of the festivities that went on. And it's amazing to me that spring break still goes on at that level, to say the least. But nevertheless, that's Florida Gulf Coast and Alabama Gulf Coast. As you heard from Dr. Rademick, there's a lot of different problems that can happen with your rotator cuff. And obviously, we can't talk about the specific rehabs of each one of these in 15, 20 minutes, but we do want to address whether or not non-operative treatment is effective for recreational athletes as well as the general ortho patients. Shoulder pain is common, especially from cuff. About 15 out of 1,000 patients or individuals will have the diagnosis of shoulder pain. About 70% will have shoulder pain in a lifetime, and about 25% will experience recurrence. Some of that shoulder pain can last for 12 months. Do all these individuals need surgery? Does rehabilitation work? Well, obviously, if we go to Dr. Google, we can get some answers. But basically, there are people that are walking around with rotator cuff tears that are doing reasonably well. The question is, for how long? So has been some studies. This one's by Riley in the Annals of College Surgery in England. And they basically stated that about 10 to 40% of the population above 60 have some type of full thickness rotator cuff tear. So if we extrapolate that information, that data, that percentage of, let's say 10% conservatively here in the United States based on the population, it would be estimated that about 5.5 to 6 million people have rotator cuff tears. Can we treat them non-operatively? Well, maybe. It's certainly a team approach where the physician evaluates these individuals and very much from a scrutinous eye to see whether or not non-op is appropriate or should they have surgery in their best interest. This is a study from the Moon Group led by Dr. Kuhn. This was published in in the Journal of Shoulder Elbow in 2013, where they had 452 patients that were treated non-operatively for an atraumatic full thickness rotator cuff tear at multiple centers across the country. And what they found was 75% were doing well, had successful treatment non-operatively at 1 and 2 years post-op. It's important to realize that there's certain criteria of this study. About 70% were small tears. The other aspect is looking at who got better and who didn't. Patients who thought physical therapy was a reasonable option did much better than people who did not. And that was the number one factor or correlative as far as getting better. Certainly picking right exercise is very important, and not doing things inappropriately for your shoulder. Sometimes bench pressing can be a bit of a problem, both shoulder and other reasons. An accurate diagnosis is where the team approach comes in, making sure it's not a cervical spine problem or some type of adhesive capsulitis or arthritic changes. Eliminating pain, addressing posture, and patients again who want to get better. So let's talk briefly about non-op key points for rotator cuff, compressive cuff in particular, and partial thickness rotator cuff tears. As I mentioned, a team approach is critical. The communication between the physician, physical therapist, and patient, and we're all on the same page with a common goal. And that's where finding out exactly what the physician feels, what the MRI looks like, is paramount to the success. Many times there's structural problems such as spurring, hooked acromions, AC joint pathology, and that needs to be factored into the equation, whether or not this is an effective treatment approach. So reducing pain. More and more literature is coming out about chronic pain of the shoulder and how difficult it may be for individuals to live with that discomfort, both everyday activities, but sometimes more importantly, even nighttime, trying to sleep, find a comfortable position. There's a lot of factors that go into how people deal with pain. Genetics, what their physical activities are, how they deal with things. What can we do from a physical therapy standpoint? Well, we can move people. Motion helps neuromodulate pain. Light level of exercise, modalities such as cold, laser therapy, and even muscle stim. And certainly the physician can help us with this with injections. Injections in my hands with patients, as far as a physician injecting and me treating them afterwards, is really many times extremely beneficial because it jumpstarts the whole program, calms the shoulder down, and allows me to work on maybe shoulder stiffness, shoulder rotator cuff pain, and so forth. Also, the therapist conveying a positive attitude toward the patient, positive feedback, teaching them coping skills. Your shoulder's bad, maybe you have a cuff tear, but it could be a lot worse. It could be more debilitating with arthritic changes and so forth. So let's go through a little bit of a program, a multi-phased approach, if you will. Gaining motion is critical. Many of these individuals, because of their age, they'll have capsular tightness. Particularly inferior capsular tightness will lead to superior migration of the humeral head, which will lead to more compressive cuff problem. So we start working on shoulder flexion using a golf club, rope and pulley, table slides, those types of things. We'll also work on internal and external rotation, again with a dowel rod or rotator cuff in the plane of the scapula, loose pack position of the shoulder, and an easy position to work in. We're always assessing capsular tightness. If your capsule is tight, let's say posteriorly, the humeral head will migrate anterior superior. If your capsule is tight inferior, it'll migrate superior with motions, and it can lead to a lot of discomfort, both in static shoulder function, trying to sleep, but certainly with active motion as well. So many times we'll do joint mobilization where we grab a hold of the humeral head and we translate the humeral head either anterior or posterior or inferior to stretch the capsule out to restore normal capsular mobility. We also do postural stretches, particularly a pectoralis major, pectoralis minor as well. Dr. Rademick talked about the balance of muscle forces, and it was a great lead in to what we do in a rehab setting. So we try to balance the rotator cuff, posterior and anterior musculature. The balance of those muscle forces causes compression and centers the humeral head in the middle of the glenoid and maintains that stability. So we work on rhythmic stabilizations, static holds, but really the key are those static holds near end range. We start out in mid-range, but we're always working toward end range where we're challenging the patient. And we'll do this for IR, ER, internal external rotation. We'll also do it for flexion extension. Scapula is critical. So postural exercises, gaining control of the scapular motion. So slow retraction, protractions, elevation, and depressions. As I mentioned before, if there's inflammation of the capsule, maybe concomitant adhesive capsulitis or some type of synovitis, but also if there's cuff bursal irritation. An injection, as I mentioned, can be very, very beneficial to jumpstart the rehabilitation. If a physician chooses not to inject, we can use iontophoresis patches with dexamethasone to calm the shoulder down. We can also use laser therapy, which has been shown to be beneficial as well. If it's more of a degenerative cuff, as Dr. Rodemick showed earlier, we can certainly do things to try to increase circulation and healing. Heat, maybe ultrasound if that's on your list, but doing some soft tissue, eccentric training, and again, laser therapy can be beneficial because it increases blood flow to that area. We may even do shock wave or piezo wave therapy, where we send pulses into the tendon and muscle to help promote healing. And there's been some nice studies illustrating tendon to bone healing with piezo wave therapy. Posture is critical, and we'll talk about this just briefly, but if we sit in a more protracted, anteriorly tilted, internally rotated posture, basically what's happening is the acromion and scapula is moving anteriorly and in an inferior tilt, which decreases the subacromial space. By decreasing that subacromial space, as you see in this illustration, it can cause more bursal wear and superior cuff wear as well. Nice study out of University of Pennsylvania showed people with compressive cuff disease, impingement, actually had more scapular elevation on the involved side, but they had less posterior tilting. And when you tilt the scapula posterior, as illustrated in this video by Dr. Kibler, you increase the subacromial space. So you give more clearance for your supraspinatus and bursa to pass through. And this is critical non-operatively, but also post-operatively after a rotator cuff repair or even a simple decompression. To help with this repositioning of the scapula, we can put someone in a postural shirt, as you see here. And these postural shirts cue the individual to get back, to get retracted and posteriorly tilted. And it gives a constant stretch on pectoralis minor. What are the best stretches for pectoralis minor? Well, when you look at the pectoralis minor, originating from the ribs, 3 to 5, and inserting into the coracoid process, it has this oblique, inferior, superior kind of orientation to it. A little bit different than this drawing. It's a little bit more on an angle than it is vertical. So when we stretch, we like the corner stretch or doorway stretch, and we have the person, we want them to posteriorly tilt as they do their stretch. So we want the scapula to move in a posteriorly tilted position and not allow the arm to horizontally abduct. That way they'll feel the stretch in front and not in the back of the shoulder. How do we know these corner stretches are the best? A study by Paul Ludwig and John Borstead from Ohio University and the University of Minnesota looked at sensors, pinning the pec minor, and showed that the corner stretch caused the greatest elongation. We can also do this lying down, use the effects of gravity, or the wall, doing a wall slide type exercise. And at our center here at Champion Sports Medicine, we have a program that we developed for postural correction. We're working on scapula, low trap, serratus. And that relationship between serratus and low trap, we like to call SALTI. SA for serratus, TI for, or LT, excuse me, for low trap, and I for insufficiency. So serratus anterior and low trap exercises are very, very critical. This is a mid-spine type exercise for thoracic spine, which is also critical to restore mobility back to scapular motion. So this young lady here is doing some opening the book, if you will, type exercise with a resistance band and encouraging that mid-thoracic type of mobility. Also, in really nice exercise here, same young lady is doing a horizontal abduction exercise in an airplane or RDL position. So we're working on scapula, but also engaging hips, which is also critical to shoulder function, the core of the body. We're also working cuff types of activity as well. So IR, ER, using a towel roll, as you saw there, is actually increasing the EMG activity by about 20%. So that towel roll is very, very beneficial. Side-lying ER in a study we did here at the American Sports Medicine Institute has been shown to have the highest EMG activity. So a very, very important exercise. And if the patient can tolerate it, we'll also put them on a stability ball and do a lot of the exercises on a ball just to create more core posterior chain. Always working scapula, seated, side-lying position as well from a neuromuscular standpoint. We may even consider doing planking type exercise, again, for the younger, more active individuals. So we're engaging hip, we're engaging shoulder simultaneously. Low trap exercise, one of the best low trap exercises is what you see here. We call it the modification of the robbery movement, where the person externally rotates, they posteriorly tilt, and they retract and bring those scapulars together as he externally rotates his arm. Serratus anterior is a very, very important muscle to the rotation of the scapula as well. And we like the exercise that Dr. Shirley Sharman from WashU developed, where it's wall slides, where the person protracts into the wall, and they can do it with a pillowcase, decrease the coefficient of friction, or a foam roller. So they basically go through this arc of motion as they're protracting and sliding up and down the wall. And as I mentioned, using a pillowcase or a towel can be advantageous to be sure that the person's not just kind of creating a lot of drag and static hold. Be sure your patients go above 90 degrees. 90 and above show the highest EMG activity of the serratus. If we do a protraction movement, I like to reverse it and do a retraction, external rotation movement where they slide up and down the wall in this ER type of position. Very nice for stretching the anterior musculature, but also very beneficial posteriorly. Long term, we put them on a fundamental exercise program of about 8 exercises that we think are important for them to do long term. And we can make this available to the participants on the ASMI website, these exercise programs. Last couple minutes here, let me just mention internal impingement. Internal impingement we see with overhead athletes quite a bit. And I'd love to get Dr. Kane and Dr. Rodemick's opinion on this. Certainly in my, I paid attention when Dr. Kane said how many years he's been here. I've been here 33 years, working closely side by side with the Andrews group. I'm very proud of that and seeing how not only pathologies have changed, but how we treat them with different rotator cuffs. When I first started, there was a lateral incision, as Dr. Kane mentioned, a mini deltoid split, which I thought these patients were doing outstanding with. But as techniques evolve, they get better and better. Some studies have been done here at ASMI looking at this internal impingement with Dr. Fleisig and his excellent team. And what Dr. Andrews and Dr. Fleisig and Dr. Kane and Dr. Dugas has shown is that internal impingement is very, very common, that it may be due to some anterior laxity of the anterior capsule, as you see here. And as a result of that humeral head sliding forward, the posterior cuff rubs on the posterior superior rim of the glenoid and labrum, which can lead to this undersurface rotator cuff fraying and superior posterior labral fraying as well. So as the arm abducts and externally rotates, perhaps the humeral head slides a bit forward. And we see this quite a bit, and it manifests itself as posterior shoulder pain. We combine that with maybe a loss of motion into internal rotation, cross arm motion. You get this discomfort right in the back of the shoulder, right in this position here at the infraspinatus and supraspinatus in the posterior superior aspect. So what can we do from a rehab standpoint? Well, we diminish the pain in the back of the shoulder. Sometimes somebody might inject it like Dr. Kane or Rodemick or Dugas. We work on range of motion, in particularly internal rotation, cross body motion. We work on reestablishing good scapular base, rotator cuff dynamic stabilization. We try to promote healing, maybe with laser therapy. Maybe in some throwers, we may even consider doing blood flow restriction. Here's my go-to stretch for stretching the back of the shoulder. I hold the scapula down as best I can, and I bring the arm across the body. and I take it all the way to end range, we can do a contract relax. I may do something to prep the tissue prior, such as heat, maybe manual release of the infraspinatus, or maybe one of the massaging guns or massaging balls as well. Really important to work on flexibility and dynamic stabilization. Again, end range stabilization of the cuff, co-activation, and then we get you back into our Throwers 10 program, which is available through ASMI, progressing to advanced Throwers 10, and then a throwing program. I think with that, I did want to mention one or two things about irreparable rotator cuff tears. I think sometimes physicians will say it can't be repaired. Let me just spend 30 seconds on this. I think 4 or 5 things if the therapist sees this type of patient. Reestablish passive range of motion as best you can, particularly of the inferior capsule. Reestablish rotator cuff strength and activation. We look for a ratio of ER to IR around 52 to 55%. We want to activate the cuff without pain. So maybe in the pool, isometrics, those types of things. Good scapula position, and watch out for activities overhead. I think with that, I'm going to end there in the interest of time. I'm going to turn it back over to Dr. Rademick and Dr. Kane for questions. Thank you very much for your kind attention.
Perfect. Thank you, Dr. Wilk. What a treat. I've had the privilege to see and hear Dr. Wilk give a lot of talks over the years, and I feel like I learned about 5 new things each time. So really good one tonight. We got time for a couple questions. Again, if you have any questions, we'll use the Q&A function at the bottom there. One housekeeping question about my talk at the beginning, looking at the shapes of rotator cuff tears. There was a question as to what that first type on the far left was. That was the most classic crescent type tear, which we typically see as small, either small full thickness or anterior partial thickness tears. For ones that progress to a full thickness tear, they're typically that kind of classic crescent type. Those then progress to larger U-shaped tears and eventually potentially that massive retracted tear that Dr. Kane talked about. One question for Dr. Kane, we see this a lot clinically. You've got a patient in your clinic that's got either a partial thickness tear or some impingement. You're going to send them to Kevin for PT. They ask about a subacromial injection and concerns for potentially making the tear worse. What are your thoughts on an injection at that setting?
Yeah, so I generally give them an option if it's a small tear or partial thickness tear. I try to let them do conservative treatment if they want to. Yeah, I think certainly you can decrease symptoms, help their bursal pain. Sometimes you can improve their function by their pain going down. They get better strength. Two concerns. One is that rotator cuff tears typically don't get smaller. So if you have a rotator cuff tear that's, say, a small 1 centimeter tear, it's never going to be less than 1 centimeter. It may be 1 centimeter for years, or maybe 2 centimeters 6 months from now. So we worry about them progressing. And number two, a steroid injection, although it's minimal side effects and minimal risk, if they have surgery soon after steroid injection, there is some evidence that it may increase the risk of infection. So if I know I'm going to fix them, I try not to do a steroid injection within the next, between a month or two before surgery. If they want to try to go without surgery, I'll certainly do a steroid and physical therapy and try to let them go for a while and see if they can make it without surgery.
Great. And then on the same subject of injections, I had a question submitted for Dr. Wilk in terms of non-operative rehab for patients with partial thickness, rotator cuff tears, or impingement. Any difference at the outset in the rehab program for a cortisone injection versus PRP?
Yeah, I mean, with PRP, we're probably a little bit slower than a corticosteroid injection. I think one thing about corticosteroid injections, people just feel so much better right away. And as I mentioned, I can't tell you how advantageous that is for a person who's had shoulder pain for months on end and they're afraid to move it and they're tight. That corticosteroid injection just allows us to not be super aggressive, but at least ramp up gradually. Whereas a PRP, many times, they're a little bit sore. It can cause some temporary inflammation or irritability in that area. So we kind of, back off as far as the intensity and almost treat it with ice and some gentle motion first couple of days. And around day 3 to 5, start gradually ramping up. Whereas with a corticosteroid, we're not doing aggressive strengthening, but we're also, but we are doing some range of motion exercise pretty diligently.
Right. One housekeeping question about access for this presentation. I believe masterclasses in the past have been posted as a link on YouTube. So we'll plan to put that out on social media. We are recording this, and so access to these PowerPoints, I believe, will be available on the YouTube link that we'll eventually post of this recording. For Dr. Kane, one post-operative question in terms of how we differentiate post-operative stiffness in the shoulder. We see patients come back occasionally, and Dr. Wilkie can jump in here as well. We see patients come back occasionally at 6 weeks or even 3 months who are stiff post-operatively. How do we determine between post-operative capsular stiffness, maybe a patient not doing fully the rehab program, versus adhesive capsulitis?
Well, I think the key is adhesive capsulitis is a totally different process. Typically idiopathic, typically not associated with rotator cuff tear, maybe a partial tear or something like that, that's just incidental finding. But if you have a true full thickness rotator cuff tear, most of those patients will get tight just because of rotator cuff repair, because they don't move the arm to get capsular contracture. We traditionally have been pretty slow. We start therapy the day after surgery, so we're aggressive there, but we're fairly slow with a patient that's struggling. We're not trying to force things, because in my mind as the surgeon, part one is to get the rotator cuff to heal. Part two is to get their motion back. Part three is to get their strength back. So, I don't worry about a patient at 6 weeks if they're tight. My experience has been that we used to not even start therapy sometimes for 6 weeks 20 years ago, and patients were really stiff and they still got their motion back. So, I don't panic at 6 weeks. I try to encourage the patient that as their pain resolves, they need to work a little bit harder and continue to stretch and continue to work at it. But I think adhesive capsulitis and setting a rotator cuff repair is very rare. There are patients that have a partial rotator cuff tear that may be repaired and had early adhesive capsulitis that was not diagnosed because it hasn't frozen yet. Those patients can truly have adhesive capsulitis, and that's a much different entity. They get super stiff. They get to where they're less than 90 degrees of forward flexion. They have zero rotation, internal external rotation. Very different from the post-surgical rotator cuff stiff shoulder.
Right.
Yeah, Mark, one of the things maybe to consider too, I totally agree with Dr. Kane, is whether or not it's a small tear versus large to massive. I become more concerned at 8 weeks, let's say push it back from the 6 week time frame, but at 8 weeks, if it's a small tear and they're really stiff. Yeah. If it's a big tear, I think Dr. Kane, please chime in as well if you believe this to be true. But if it's a bigger tear, like large to massive, and they're a little stiff, I almost feel good about that. That means they have a good healing response, and because we worry about those big tears, they have a higher failure rate. The other thing that's interesting, and I'd love to hear your two gentlemen, your two opinions on it, is a study by Parsons and Flato that basically showed that people who did get stiff had a lower failure rate. Have you found that to be true? And what are your thoughts on that in regards to that study that was done quite a few years ago from New York?
Yeah, that's kind of my point. My point is that I think patients have such a wide variety of reaction to rotator cuff surgery. My patients come in a lot of times, they're freaked out. They say they've heard the worst thing in the world is terrible. It's worse than childbirth, worse than a heart bypass, worse than anything they've ever had. And really, I think if I take 100 patients with rotator cuff repairs of all kinds, all shapes, all sizes, about a third of them say it's not bad, honestly. About a third say, yeah, it's bad, but it's kind of expected. And about a third think it's the worst thing they've ever experienced in their life. And so what causes that? Is it something we do in surgery? Is it something that happens? Is it their nerve endings were more sensitive? Is it sensitivity to something we do? I don't know what it is. The stiffer the patient early on, the better I feel about them, because there's no doubt in the old mini open days when we didn't let them do much early, I think they healed better because they didn't do anything. And that's why some because the concern is that the patients tend to overdo it. Our former executive director, Kevin, I think you did his rehab. We did his rotator cuff 15 years ago, and he was at a meeting a week later with his sling on, pointing everybody where to go with his arm up in the air. with none of the restrictions that we had set for him. So I think the people that have less pain certainly probably have a higher failure rate, which is terrible. But it's the truth. That's why I said stiffness doesn't bother me. I kind of like it because I think it keeps people honest. I don't want them to be in pain, but if they're not in pain, I really, really, really try to stress to them how important it is to be careful, because I think they tend to overdo it.
Very good. We've got a few questions that are rolling in. Dr. Kane and I have both been on these panels with Dr. Wilk in the past, and this is pretty standard that the questions for Kevin typically come in at about a 2-to-1 or 3-to-1 ratio. So we've got a few lined up for Dr. Wilk here. So for Kevin, criteria for sending a patient with impingement to one of the physicians for an injection. And then also our friend Lenny wants to know about early range of motion. We talked a little bit about waiting. Dr. Kane talked about historically, we wouldn't move patients early on in the rehab process. Now we're all about kind of early motion. Is it safe to do this with small and medium repairs with decent tissue?
Yeah, so the first question regarding the injection, obviously you all, physicians see the patient first. Maybe you didn't inject, sent them to therapy, sent them to me, let's say, and we're struggling. They have a lot of pain. They have loss of motion, a lot of night pain, just kind of miserable, and we're hitting a plateau and we just can't get over it. That's when I'd contact you, Dr. Ottermick or Dr. Kane, and say, hey, I need some help maybe with this patient. Maybe if you can get them in or get them in the next time you see them and think about an injection. And, it's great having that open door policy where we can communicate and see what you think about the situation. Not always do they get an injection, but again, I think if we're hitting a plateau in rehab and we're not progressing, I think we have to do something about it, especially with limited visits and so forth. And as far as Lenny's question, without a doubt, I mean, with smaller tears, I personally don't have a problem moving people right away because I'm going to move them philosophically in a very short arc of motion. And the only reason I'm moving them is to neuromodulate pain. So they'll do a little bit of IR, ER. They may do a little bit of a table slide, but they're not doing anything overhead. They're not doing any active assisted overhead. So it's pretty low level, low EMG activity. And they're really taking it to their point of restriction, but we're not pushing motion. And we just want to gradually increase the motion so we don't get behind. And as Dr. Kane mentioned, big tears rehab differently than small tears. Small tears will move quicker. Larger tears, we're really slow with them and they're barely moving. And the reason being is we want to lay that scar. As everybody knows, these cuff repairs, it's all scar that's forming. And the last thing we want to do is overstress that scar, especially with big tears, because they have poor tissue to begin with.
Great. One last question before we call tonight. We can start with Dr. Kane and have Dr. Wilk jump in on this as well. Specifically for injecting patients in the clinic, we talked a little bit about the rehab for corticosteroid injections versus PRP. So Dr. Kane, in your clinic, are there any specific types of patients or types of rotator cuff pathologies that you would recommend corticosteroid versus PRP versus there was a specific question about lipogems? Any specific indications for one lane of injections versus another? And then for Dr. Wilk, any differences in rehab outcomes for those different types of injections?
Yeah, so it's a great question. I primarily use corticosteroids because I think a lot of the problem early on is inflammation in the bursa. I know the biologics, there's a variety of biologics from PRP to bone marrow aspirin concentrate to, all kinds of fatty-based, liposome-based things to amniotic fluid. There's placental, there's a gazillion things that are biologic out there that nobody really has any data on, any good data. But I think on the biologic side, the theory would be that you're trying to cause inflammation, cause a healing response, which we do for, say, patella tendonitis, lateral condylitis, those kind of things. Whereas with rotator cuff, maybe for rotator cuff tendonitis, if you put it in the tendon, it would help. But I don't think that's what people are doing. People are putting it subacromial, which doesn't make a lot of sense to me. I think if you're going to do a subacromial injection, corticosteroids make more sense. Unless you're going to do an ultrasound guided into a tendonitis area with PRP, then maybe PRP makes sense. I don't do all of those. If I do have those patients that want PRP or some kind of biologic, I send most of them to our non-surgical doctors that do the ultrasound guided injections. But the steroids seem to be great. You can't do a bunch of them, obviously, because it can cause some tendon degeneration. But that's my primary go-to.
You typically do PRP for revision, surgically, intraoperatively for revision rotator cuff, or any specific indications for PRP?
You know, we Dugas and I did a series of several revision rotator cuffs where we did bone marrow concentrate, thinking that would help, and we couldn't see a difference, and it cost, you know, $3,000 so out of pocket for the patient. So we haven't done it routinely. You know, I think probably a bigger series needs to be done to look at that. There was, you know, one series in Europe, I think it was in France, that showed really good results for using bone marrow concentrate with revision cuffs. We couldn't get that same result here. So we've done it in certain situations where the patient's really adamant about it, but we don't do it routinely.
Excellent. I'm always impressed by the quality of the questions for these. Not a lot of chip shot questions tonight. Well, thank you very much to Dr. Kane and Dr. Wilk. Always a thrill to get to chat with you guys about different topics and all about rotator cuff tonight. Great questions from the attendees. Again, this link will be available on the website and on YouTube. Thank you for your questions, and hope everybody has a great evening.
Thanks, guys. Appreciate you guys.
Thank you. Great job, Mark. Thank you, Dr. Kane.